Namaste everyone, I am Dr. Vaskar Humagain and today I am going to present my abstract presentation on posterior tibial slope in adult Nepalese population. My guide is Professor Dr. Krishna Prasad Poudel and my co-guide is Dr. Arun Sigdel. These are the contents of my presentations. I'd like to begin with introduction. The posterior tibial slope is a slope directed posteriorly and inferiorly relative to the long axis of the middle of the shaft of tibia. It may vary according to various demographic variables like age, sex, body mass index and ethnicity. It may range from -5 to 24 degrees and it can be measured indirectly using radiographs or directly using cadavers. These are various radiographic methods for estimating the posterior tibial slope either through the midline axis, either through the posterior axis or through the anterior cortical axis of tibia. Literature insists on increased PTS. Literature say that increased PTS increases shear force and anterior tibial translation. However, it reduces stress based on the native posterior cruciate ligament. Thus, posterior tibial slope influences sagittal alignment and the kinematics at the knee joint, and knowledge of this slope helps in surgeries around the knee joint, particularly total knee arthroplasties, arthroscopic ligament reconstructions and high tibial osteotomies. The objective of my study was to calculate the posterior tibial slope in adult Nepalese population. The specific objectives were to estimate the average posterior tibial slope, to compare any laterality, that is difference between right and left sides, to assess the correlation of the angle with the age, to correlate PTS with the body mass index, and to ascertain differences in between various ethnic groups and their statistical significance. It was a prospective observational study with sample size of 185. The inclusion criteria were those people presenting to the outpatient or the emergency department with minor injuries around the knee, and the exclusion criteria were those with fracture dislocations around the knee or those with advanced osteoarthritis evidenced radiographically. Those who fitted the inclusion criteria were asked for x-rays of the knee joint. Our focus was on the lateral x-ray of the knee joint, and to obtain the true lateral view we kept the patient supine with about 25 to 30 degrees of flexion and beam directed perpendicular to the knee joint. Coming to the results, our average posterior tibial slope was 10.35 degrees with an standard deviation of 2.03 degrees. This picture depicts the age distribution, and the average age was 41.25 plus minus 15 years, with males having slightly greater mean age and females with slightly lesser. However, the range was 19 to 82 years, and there was no significant correlation of the age with the posterior tibial slope. Our study comprised of 52% males and 48% females, and there was no any sexual dimorphism present in our study. There was no significant differences between the right and left knee as per our study, because the p value was not significant. The mean height of the study population was 164.09 centimeter with an standard deviation of 8.30 centimeter, and it was not significantly correlated. However, the mean BMI correlated with the posterior tibial slope significantly with a p value of 0.017. %48% were RNs, whereas 52% were non-RNs in our study, and there was no significant differences in the posterior tibial slope with regards to the ethnicity of the study population. Coming to discussion, this is one of the first studies done in Nepal regarding the posterior tibial slope. B.R. Adhikari et al. Did a similar study in 2016 with regards to the non-contact, with regards of PTS to the non-contact ACL injuries. There are several studies which I have compared here, and this finding is similar to the finding around our subcontinent like India, Pakistan, Malaysia. Similar findings have also been found in Switzerland, South Korea, South Africa, UK and the US. The age group of our study was similar to that found by various Indian authors as well as R. Hudek et al. Similar to our study, males were more than the females in the study as found by two authors. However, females were more than males in the study done by several authors like Hashemi et al., Muthuri et al., Nekanti et al., and Meda et al. There was no significant difference in the posterior tibial slope between the two genders in most countries except Pakistanis and Americans. The basal body mass index correlated with PTS significantly in our study. There are paucity of studies regarding the correlation of BMI with PTS. In a study by S. Meda et al., the BMI was not correlated with the PTS. Ethnicity did not significantly correlate with PTS as in the studies of ours and Yoga et al. Positive correlation in the study was done by D. Boyle and Haddad et al. Regarding the axis of used as reference, we used longitudinal anatomical axis as done by Kuano and Mohanty et al. Han et al. Described 4 different axes for calculating, and Yu et al. Found significant difference of PTS when measured through this axis. The limitation of our study was medial and lateral posterior tibial slope was not measured separately in our study. We calculated with plain radiographs only. We did not use CT and MRI. It was a hospital based and not community based study, and it was not carried out in advanced osteoarthritis. Hence, to conclude our study, we have found the PTS to be 10.35 plus minus 2.03 degree and only correlated with the body mass index. The effect of increased or decreased PTS on non-contact ACL and injuries is a new subject, and that must be carried out in the future. Thank you. This concludes my presentation. Thanks for your patience.